Hi, if you're just joining, we're going to give people time to join this. We are going to do a live question and answer panel with the morning speakers, and we'll get started in a minute or two. Okay, well, we have a lot of questions to go over, so I would like to get started. My name is Rick Labuda. I am the Executive Director of Concord Chiari. I am joined by Dr. Francis Loth, who was one of the co-founders of the Concord Chiari Research Center at the University of Akron. He then has since moved to Northeastern University in Boston, where he heads up our Chiari research there. I'm also joined by Dr. Philip Allen, who heads up the Chiari research now at the University of Akron, which is focused on the cognitive emotional impact. Thank you, gentlemen, for those great presentations. And I've collected some questions that were asked during the presentations, and we are just going to dive right in. So Dr. Loth, have you done any imaging on Chiari patients to compare CSF flow after being upright for 12 hours? Many Chiari patients experience an increase in pain and pressure by the end of the day. I am curious what mechanism causes this. Is it an issue of compliance or obstructed flow?
Thank you, Rick. That's an excellent question. Unfortunately, I don't know the answer to that question. We have definitely scanned Chiari subjects late in the day, which presumably they had been upright for 12 hours, but we didn't take note of that timing as to when they, when the scan was performed relative to how much time they were upright. I think it's a very intriguing question. I would like to think about it further. We could maybe do a study on that, but in some sense, we need to do, each person has different CSF flow, so we would have to use each person as a control. We'd have to have them come in the morning and then have them stay upright all day, and then come in the evening and do that scan. That's not impossible to do, but it can be expensive with $500 to $1,000 an hour for each scan that we do. But I like that idea of looking into that, and compliance probably would be an aspect of that.
So let me ask you something, Dr. Loth. People's neck muscles tend to get, Chiari patients' neck muscles tend to get very tight after being upright. Do you think that tension is enough to change the compliance in the cervical region?
I think it is. It's not been proven, but I think it makes sense with the myodural bridge connections to the dura. I think it's possible that it could be extending the dura into a sort of stretched state when the muscles are tight, so that there's limited compliance in that canal. But again, that's just a hypothesis. That's not proven, but I do think it's a strong possibility.
All right, thank you. That's an excellent question, and it's definitely a research project that we will look into. Dr. Allen, what role do sleep issues, which are common in Chiari patients, such as apnea, what role do you think they play in the cognitive deficits that are experienced by Chiari patients?
Very interesting question, and we are about ready to start a study on this in Chiari. But historically, when you have what we would call sleep deprivation, if you're woken up multiple times during the night, either due to sleep apnea or insomnia, the most typical symptom that occurs with regard to cognitive performance is greater difficulty in focusing attention. So we first started doing sleep deprivation studies in so-called healthy younger adults in the 70s and even late 60s. And the major finding was that people had a hard time focusing attention. That was the largest effect. So if it's due to a loss of sleep per se, it's probably going to be a focused or selective attention deficit.
So let me ask a follow-up to that. With studies outside of Chiari that have looked at sleep deprivation, do they ever see the fiber tract damage in the brain that you have seen with Chiari patients?
Well, I am familiar with the literature in schizophrenia, which is very different, but they do also have sleep issues, and there is a loss of prefrontal volume in the prefrontal cortex. The thing is that due to the sleep deprivation, or is that due to something else associated with schizophrenia? And my guess is that it is. I know of no evidence of sleep deprivation itself causing fiber tract damage, but there are some intriguing things that one could look at, Rick. And one, the idea is when you're asleep, the main job of sleep in many ways is to clear debris from the brain. If it is true that you're interfering with that process, you could have an increase in brain inflammation. And that could be, then you could get your fiber tract damage from that. And that is just a fascinating thing to study. And some people are starting to do that outside of Chiari.
And we should probably point out that the research is very clear, the general research, not Chiari research, but in general, the research is very clear that disruptive sleep patterns do increase the risk of dementia in later life, correct?
They are associated with it, but the question is, which came first, the smoke or the flame? My suspicion is that it's the brain damage associated with the dementia that's resulting with less sleep. But that's an interesting idea. Okay,
let's move on. Another topic that was raised during the presentations that is commonly asked by a lot of people is patients are often told by clinicians that they've had the herniation their entire lives. Now we can set that question aside as to whether that's accurate or not. But the main question that they say is, why do symptoms develop at different points in life? Some people, the most common age for adult Chiari, the late 20s, early 30s, where symptoms are recognized to the point where people are diagnosed. Yet some people attending today have not been diagnosed until their 60s or 70s. I'd like to hear both of your thoughts on that. Let's start with Dr. Loth. You're muted, Frank.
Yeah, I don't have a good understanding of why some would have present with their symptoms later in life than others. I don't have a theory on that. One of the things that doctors always tell me is that you need to treat pediatric Chiari strongly different from adult Chiari. But I think what you're talking about is whether they're, in their mid-20s or whether they see it in their 50s and 60s. And I don't know the reason for that, except for maybe environmental changes, things that they do, sort of damage from car accidents or some sort of physical activity. But it doesn't make entire sense to me, because the tonsils over time generally move up as you get older with each decade. So you should arguably have less crowdedness as you get older. Sorry, I don't have a better answer.
That's all right. But that is something we have to figure out, right? That goes into this whole idea that we need a better understanding of the pathophysiology of symptomatic Chiari, and so that we can incorporate, and that is one of the clues, is that people develop symptoms at different age. But I would just comment that both anecdotally and research, it is clear that environmental factors, not air pollution and things like that, but people's activity levels and traumas do play a role. Right. So in one sense, people can have an anatomy that is prone to developing symptoms. And then based on, whether they've done a lot of sports or physical labor, or had been in car accidents, experienced whiplash, things like that, gone through pregnancies, those can add up, and then you can become symptomatic. So that doesn't necessarily explain it at a detailed level, but at a high level, the environment, I think, is pretty clear, it plays a role.
I think that's definitely true, with the one caveat that it's impossible for us to prove that beyond a shadow of a doubt. We have to do MRI images of someone and then monitor all of their
Right.
environmental for 20 years, but I think it's perfectly reasonable what you're saying. And I believe Phil has been in contact with neurosurgeons that say they're seeing an increase in patients in their 60s. Isn't that right, Phil?
Yes, in particular, Dr. Klingham, who is participating today.
Okay,
Is
Phil,
she
do you have
seeing-
anything you want to add to other possibilities of why people develop
Sure.
symptoms at different age?
Yes, in fact, all three of us just had a paper appear in 2022 that is very close to this topic. There are some issues. I mean, Dr. Loth can talk about age-related decrease in compliance as we get older that could account part of that. We, in fact, had a study where we compared 18 to 60-year-old Chiari patients using MRI-based data. And we found out that, in fact, pain, self-reported pain, using a standardized measure of pain, increased across age, which is consistent with the idea that this question came from. In spite of the fact, like Frank mentioned, that the tonsils weren't as far down as people became older. What did change is what we call the anterior CSF area between the bottom of the second cervical vertebrae up to the foramen magnum on the front side toward the neck got smaller in Chiari patients as they got older, and that was correlated with pain. In fact, that anterior CSF space mediated those age-related pain increases. So that's one possibility. Something is going on with the cervical vertebrae in Chiari patients, and as they get older, they have less CSF space.
Okay,
but there's
thank you.
another possibility, and that is what I would call the snowball effect of so-called disease load. And it's not really disease load, it's what we sometimes in other papers have called allostatic load, which is how much stress the body can take. If you start out when you're 20 and have a certain pain level, and it keeps going on up until you're 60, you have a cumulative effect that rolls up like a snowball. And you have a cumulative increase in the experience of different symptoms. And that is what I think a pain neurologist would argue is probably the simplest explanation of this. But even with the age of, I believe the age of decompression surgery, it peaks at, I think, isn't it, Rick, about 34 years of age?
Yeah, it's the most common, yeah.
Yeah,
Early
so
30s.
even decompression surgery ages are later than what you might expect.
Right. All right. Let's keep moving. There are a lot of questions, but Phil, I am going to stay with you. People would like you to go into or provide a description of ACT therapy, ACT therapy, and maybe you could talk a little bit about what that actually entails from an experience point of view of someone going through the process.
Yes. And I will go over what ACT therapists think is going on, and I will go over what I think is going on, which is not completely the same, but they're very related. So ACT stands for acceptance and commitment therapy. It is a variation of mindfulness. In other words, a yoga-like intervention. And the idea is that you have a constant background or even foreground, a so-called prepotent pain effect. You have pain constantly going on. And if it comes to the forefront, then it's interfering with everyday function, like your everyday activities, whether that may be trying to remember to take medication or remembering to go to work and being able to concentrate at work. So ACT therapy is designed to help you cope with pain. It doesn't take the pain away, but it helps you to build up a wall and block that pain in the background. So in mindfulness, the idea is you accept the pain. But what I think is going on in your brain is that you're learning to inhibit the pain, inhibitory control. And we even have some evidence of this occurring in diffusion tensor imaging images for Chiari patients show increase in the density of fiber tracts associated with pain inhibition in the anterior cingulate cortex.
Hang on a second, Phil. Hang on a second. So what in a session, like what would someone do?
So you work on problems and say, all right, what is your daily routine? And how does this pain or other disability interfere with those daily routines? And what you have homework too, to work on this after the session, to learn to really put that pain in the background and learn to put the daily tasks in the forefront. And that seems really simple, doesn't it? But it's not that simple. And this is the only pain intervention that is accepted as working by the American Psychological Association. And
I would just like to add that our research is ongoing in this, and that in addition to the early stuff, we have tried doing this, delivering it through an online basis so that the reach is broader, and that we are currently doing a study to refine that protocol. And hopefully within a year or two, we could potentially roll this out as a service to the Chiari community, correct?
Yes, and the research from this, based on a sample of 52 people, was that ACT therapy does not lessen the pain level, but it substantially increases your ability to cope with it.
Right, and to engage in activities.
Yes.
Right. Okay.
Yes.
Let's get Dr. Loth back involved. But actually, before that, here's an interesting question that I might address: is there a connection between obesity and Chiari? And that's a complicated question. That gets back to what type of connection you mean. The Chiari 1000 data is pretty clear that the average BMI of Chiari patients is extremely high. Now, why that is the case is not known. But one project we're about to undertake this year yet is to actually, within the Chiari 1000 data, look at high BMI Chiari patients versus low BMI Chiari patients, and look at all the different data that we have about them through the Chiari 1000, such as their morphometrics, such as their symptom history, their diagnostic history, things like that, and see if it's really kind of different subgroups. And within that, you have to be careful, because there is the connection with intracranial hypertension, which is also linked with obesity. But that is a good question. Dr. Loth, another topic that came up quite a bit are the balance issues associated with Chiari, and do we have any insight into that?
So, I mean, we definitely have been looking into that quite a bit recently. We did as described in the presentation, we did a lot of work on looking at the tissue strain in the brain, in the cerebellum and the brainstem, and we identified specific nerve tracts that would be important with balance, because we thought if we looked at the strain on those nerve tracts, specifically the nerve tracts that are associated with balance, we could then show that those nerve tracts were experiencing greater strain and maybe damage. The results did not show that. We did not see a difference in the strain due to a cardiac cycle between those with balance problems and those without. So this so that was kind of a surprising. We thought we might see something there, but we think that maybe coughing is a more abrupt, or sneezing might be a more abrupt event and cause greater strain. So even though we looked at the cardiac cycle, we're now looking at a new technique called pencil beam with Dr. Bedelia, and we think that we can measure those same tracks using the pencil beam and have the patient cough very gently in the scanner. And then we're hoping to do that comparison for those studies as with balance again. So we're looking into that.
Thanks. So I think it's important to point out that the balance system in a human is a complex system, and it does involve more components than we looked at with the strain. So those strains could be part of it, but maybe not take into account the other features of the balance system, correct?
That is true. That's very true.
Okay. Phil, Dr. Allen, a very specific question someone just put in. Have you explored balancing estrogen and cortisol levels to see if this helps balance the psychological effects?
We have to be very careful about manipulating estrogen levels, particularly depending on your age, because it can have, there is a difference between what we might call an endogenous control of estrogen levels versus a drug-based one that can have, in some cases, a negative side effect. But you certainly can look at the effect of cortisol based on a manipulation, a stressor task. But there are other ways we could look at that. Estrogen is downstream after a while. So it's the neuroprotective hormone that helps overcome chronic activation of stress hormones, for example, like cortisol or interleukin-6. But that kind of study could be done maybe another way by looking at event-related fMRI. That actually would be a neat study where you could have a pre-baseline fMRI and then have a stressor task and take the cortisol assay from that, and then put a person back in the scanner and look at the event-related fMRI. And you can, by the way, you can even look at stuff in the cerebellum related to balance and the brainstem on that.
Okay, we have a couple more questions people are asking. I think we have a ringer asking a question. Dr. Robert Friedlander, Chair of Neurosurgery at UPMC, who will be presenting later today, asks for thoughts on why Chiari is so much more prevalent among adult females than males.
Well, you want to try that first, Frank, or do you want me to?
I was thinking I would have you try that.
Okay. Well, this is still hypothetical, but I do think that you have differences in reactivity in males and females. And by the way, sometimes the difference in reactivity is positive.
So can you define what you mean by that? Can you define what you mean by that?
In particular, emotional reactivity. And here, let's assume that females do have more emotional reactivity. And from a physiological and neural perspective, there is no doubt that they do. That helps in memory, by the way. Women have better episodic memory than men do, probably due to that. And the thing is, of course, the more women that are adults have Chiari than men, but in pediatric cases, it's pretty balanced, or there might even be slightly more boys that are diagnosed with Chiari than girls. And this suggests that something happens perhaps at during adolescence, a change in hormones that again is related to that. So I still say it is related to estrogen.
Frank, do you have any thoughts?
Well, just to add to that, we explored some large databases to try and pin that down, and the databases are somewhat difficult to work with, or in terms of understanding their accuracy. But it was national database, and we could see a crossing point, somewhere around 14 years old, where the boys and the girls were about even. And as Phil said, there's even slightly more boys at the youngest age, but then after 14, then females took over, almost a 2-to-1 situation. But I agree with Phil. It's got to be something with adolescence, puberty changes, but I don't know the biochemistry.
We should also point out that, Frank, I think it's important to point out that from a morphometrics point of view, that is the age when the clivus bone, which you talked about in your talk, completely finishes fusing. So you could get a divergence in that sense as well, from a morphometric point of view.
And with this large ABCD study, we will have a good window into how the morphology of boys and girls change. The ABCD study is probably in its 3rd year, or maybe almost done with the 4th year. So we're going to have kids' MRI scans from 10 to 20 years old, literally thousands of kids, 11,000, more than 11,000 kids. So we're going to know what normal function of that clivus bone, which is not published in the literature, by the way, at least in the way that we'd like to discuss it in terms of its shape. But again, the clivus bone, it's definitely pointing to that clivus bone very often, but we don't know how that clivus bone plays a role in the whole thing.
That is a good that's important to clarify.
Should we
hang on, Phil? I want to try to get a couple more in here. Very, very specific questions. People are wondering if there's a way they can establish their own cognitive baseline.
Absolutely, there is. So there are so-called brain training software applications available that you can use to monitor your. Many of them emphasize attention too, which is crucial for Chiari malformation, particularly inhibitory control, so-called Stroop-like tasks where you have to inhibit something. And you can have a baseline and then keep tracking that over time with these so-called brain training software packages.
Okay. We had a couple kind of logistical questions here as far as participating in research that I will take on. In general, people always want to know how to participate in research. And the answer is that Conquer Chiari in general will announce projects that are looking for participants on our website, through social media, and through our email list. So you could join the email list, or check our website, or join our Facebook page, and you will find those announcements. There's a section on the homepage about active research studies. There's one going on right now, correct, Dr. Allen, that web-based study that
Yes.
people can participate in. Now, as far as ones where we have research projects where we're using clinical partners, that's a little different. Then the participants come from the patient flow of that specific clinic. So we generally don't advertise those because that would kind of skew things in that regard. Another question about this was whether we will do international studies. And it's a little tricky. Like the Chiari1000 was open to participants worldwide, and we do have people from many countries, both English speaking and non-English speaking countries. So any web-based type projects are generally open to participants. And then as far as clinical studies, again, if that person happened to get treatment in the US, maybe they would participate. But from a legal point of view, it gets extremely tricky for us as a US-based operation, an organization, to fund a clinical type study in a foreign country. So that is not likely to occur. With that, I'm going to wrap up this panel. I want to thank Dr. Loth and Dr. Allen. We will hopefully we addressed most of your questions. There are 2 more panel sessions throughout the day. So if you asked a question in the Q&A section of here that was a little more medically focused, maybe you could ask that again in the clinical panel session, which is after the next 3 presentations. But right now there is a break. I encourage you to explore the poster hall where you can read in detail about all the great projects that are going on, or jump into a roundtable discussion with each other and make some new Chiari related friends. Thank you for joining. Go ahead, Phil.
We have a paper we are about to submit that is germane to the gender differences, the sex differences by age. And in fact, there is some pretty interesting data about anterior CSF area that adult females show a decrease in it compared to males, but girls do not show a decrease compared to boys.
Right. Okay.
So
when that comes
coming
out,
up,
we will,
so bear with us.
when that gets published, we will of course post a summary of that on the Concord Chiari website and push it out as part of our research updates. So again, thank you to Dr. Loth and Dr. Allen, and thank you for everyone who participated in this. And we will check back in later in the day. Thank you.
Thank you.